post-transplantation. Radiological diagnostic methods have a significant role in the preoperative and postoperative care of patients after kidney transplantation. Improvement in technology lead to early detection of complications in the postoperative period, which are the leading cause of transplant failure. This presentation will offer a brief description of the imaging modalities usually used in the evaluation of renal allografts, with a special emphasis on the new techniques that are utilized to assess renal transplants. Diagnostic imaging methods include ultrasound, CT scan, MRI, and angiography. Grayscale ultrasound provides morphological details of the allograft, such as position, form, and relationships. It differentiates the two components of the renal parenchyma, cortex and medulla. Ultrasound criteria for the diagnosis of allograft dysfunction are allograft enlargement, hyperechogenic cortex, and hypoechogenic medulla, with the unclear delineation of the two structures. Liquid collections may appear surrounding the allograft or the nearby organs. It's worth mentioning that the possibility of the new ultrasound machines to detect and characterize blood flow in medium to small vessels in the allograft. Color Doppler ultrasound measures the blood flow speed in centimeters per second. The ratio between systolic and diastolic velocities is called impedance index and correlates with the quality of the parenchymal circulatory bed. Contrast-enhanced Doppler ultrasound includes observational, quantitative, and semi-quantitative assays. On the left side, the image created by fundamental echoes. On the right, the harmonic vascular image in the early arterial phase to notice the enhance at the level of the segmental arteries followed by the arcuate arteries. In the delayed arterial phase, it is noticed that full enhancement of the cortical parenchyma. In the medullary phase, also called nephrographic phase, the contrast agent is uniformly captured in the renal parenchyma. The quantitative analysis is focused on the dynamics of the transit of the contrast agent through a specific Roy and aims to measure perfusion parameters related to the circulatory bed and representing time intensity curve. The semi-quantitative analysis consists of superimposition of color map over the ultrasound image. Shear wave elastography is a good non-invasive tool to assess renal fibrosis in early stages. This is an example of shear wave elastography where 10 measurements of kidney stiffness using circular regions of interest are placed at the nearest region from the skin with a well-represented renal parenchyma. The mean value is calculated and considered indicative of fibrosis. Therefore, shear wave elastography may be useful for the prediction of fibrosis, can be of great help during regular follow-up, can be used as a screening tool, and can aid in the early diagnosis and management and help in selecting patients who are candidate for biopsy. New MRI techniques include ASL, which is the arterial spin labeling, blood oxygen level dependent, dynamic contrast enhanced MRI, sodium magnetic resonance imaging, supermagnetic iron oxide imaging, and MR elastography. ASL utilizes magnetically tagged water as an intrinsic contrast agent, so it is safe in patients with renal insufficiency. A control image is obtained without contrast, then a pulse is then used to magnetize the blood. The labeled image is then subtracted from the baseline image, generating a map of the signal difference created by the perfused blood. Decreased oxygen levels are an important part of the pathogenesis of both acute and chronic kidney injury. Blood oxygen level dependent MRI is a method that utilizes difference in the magnetic properties of oxygenated and deoxygenated hemoglobin to evaluate tissue oxygen levels. This is bold MRI grayscale image showing A, normal kidney, and B, kidney with graft dysfunction, and color maps images C, normal kidney, and D, kidney with graft dysfunction. Dynamic contrast enhanced MRI is a method in which MRI is used to monitor kidney perfusion and the filtration of the contrast agent through the kidney. This is a dynamic contrast enhanced MRI showing acute pyelonephritis. Sodium MRI is a method that measures sodium cations instead of hydrogen protons. Tissue sodium stores are higher in patients with acute kidney impairment than in healthy controlled subjects. Picture B shows color-coded image of a human kidney under normal conditions, while picture C shows sodium image of the same kidney after 12-hour water deprivation. Inflammation causes vascular leakage and edema formation in tissues. This can be visualized by T1 and T2 mapping of MRI as a measure of tissue water content. Supermagnetic iron oxide are phagocytosed by macrophages. Accumulating in inflamed tissues, they can therefore be used as a molecular imaging probe within the kidney. Renal MRI of a patient with acute tubular necrosis before and after the injection of the particles. And this difference is due to a phagocytosis of the particles by the macrophages due to inflammation. Kidney fibrosis is a hallmark of most forms of tissue injury. Diffusion-weighted imaging is used to get a map ADC value correlate with the decreased kidney function. And here, diffusion-weighted image show in picture E, patchy areas of restricted diffusion, and the picture F ADC map shows multiple patchy areas due to decreased perfusion. MR elastography can be used to measure kidney stiffness as an indicator for fibrosis. Image B shows the corresponding stiffness map for the same kidney, where blue represents softer tissue and red represents stiffer tissue. Color bar is shown on the side. To summarize, many promising new imaging methods and tools that may help in the detection of kidney disease are currently in development. Although these methods have not yet entered the clinical practice, many of them can be performed using imaging machines that are widely available. The new methods are therefore still mostly used within clinical studies. Better imaging methods hold great promise to early diagnosis and for safely monitoring the response of patients who undergo treatment. Thank you.
Sally, for your concise and very elaborate presentation. And now